കാസർഗോഡ് എല്ലാ പ്രേക്ഷകർക്കും മെഡിട്രാക്കിലേക്ക് സ്വാഗതം. ഇന്ന് മെഡിട്രാക്ക് ഡിസ്കസ് ചെയ്യുന്ന വിഷയം ഇൻറ്റൻസീവ് കെയർ യൂണിറ്റിനെ കുറിച്ചാണ്. ഹായ് സർ, വെൽക്കം ടു Meditrack.
Thank you.
See doctor, we can see that many hospital casualties, emergencies and intensive care units. Actually, what is these three things?
So, as the patient comes to the hospital first, the first thing is they go to the emergency care. That is the casualty, what is usually called as.
Okay.
There the emergency physicians will be there.
Okay.
So these physicians will look at the patient and assess the patient and how bad they are. According to that, they stabilize the patient first, and then they decide whether the patient is fit to go to the wards or need a treatment in the ward, or whether they can go home, or whether they are pretty sick enough to be shifted to ICU.
Okay.
So these are the emergency physicians who are seen in the emergency as like a casualty.
Okay.
So later on the patient comes to ICU or the ward.
Okay. See, doctor, recently we have seen that intensive care unit is a particular department is there. Actually, what is intensive care unit?
Intensive care unit or critical care unit is it's a crucial part of the hospital or healthcare system where the critically ill patients or sick patients are kept. Okay. See, the patients who come in with a pretty sick condition,
okay,
they require a continuous monitoring system, and they require a lot of intensive nursing care, and sometimes patients will have organ failures. So these patients will not be able to manage in the wards. Okay. So we require these specialized units called as ICUs. Okay. So this is called as intensive care unit. So usually there are three kinds of ICUs in a hospital. Okay. Level 1 is a place where only the monitoring systems are there. Okay. And the patient who are stable, who require only monitoring, like post surgery, okay, they require to be monitored. Or cancer patients who are getting chemotherapy, okay, they need to be monitored. Such patients are kept in this level 1 ICU. Level 2 ICU is where the little sicker patients are there. Okay. These patients require little bit more of nursing care. So here patient to nursing ratio will be slightly more. Every 4 patients, 1 nurse will be available. So, and then we come to the level 3 ICU, which is a critical care ICU. So which is a full-fledged ICU where patient is much sicker patients are kept, and these patients will be having organ dysfunction. Okay. So such patients are kept there in the level 3 ICUs, and they are treated there. The nursing ratio also is more here. So depending on how sick is the patient, either 1:1 or 1:2 ratio of patient to nurse ratio will be there.
See, doctor, naturally we have seen that what kind of patients are entered in intensive care unit most of the times?
So as I said, first when the patient comes to emergency, they will triage the patient and decide which kind of ICU patient is required. Patient who is having little bit stable patient who are requiring a very minimal oxygen but having a little bit of monitoring is required. Such patients will level 2 ICU is sufficient. Okay. If patients are having organ failures or patient is patient is pretty sick, his BP is very low, patients having organ failure like a respiratory failure is there, cardiac failure is there, or patient requires organ support system like a ventilator, dialysis. Such patients are shifted to level 3 ICUs. Okay. And here these are, other than this, some patients come with internal bleeding. Okay. So those patients also has to be monitored and blood transfusion has to be given. Those patients are also kept in ICU. And neurologically sometimes there are seizures are there. Patient come with paralysis and they need to be monitored in the ICU. So, and then poisoning cases, road traffic accidents. Okay. So these are the patients who require more care compared to the ward patient and level 1, level 2 ICU patients. Okay. So such patients are kept in level 3 ICU patients. ICUs.
Okay, doctor. See, actually, who are managing this kind of patients inside the intensive care unit or in this ICU?
Actually, it is a multidisciplinary team. Yeah. Here in the level 3 ICUs, we'll be having intensivist or critical care specialist, what we call as. Okay. These are the physicians who are either a background of anesthesiology, internal medicine, or a pulmonary medicine as a post graduation. Okay. Post that MD, they get a training in critical care. They take a training in critical care for 2 to 3 years, and then we come as a intensivist to the hospital, and we take care of the ICUs 24/7. In our hospital we have around full-time 5 intensivists who along with our junior senior residents manage the ICU 24/7. And in our region we are the only hospital who gives a coverage for the ICU. Manipal Hospital is the only hospital which gives a coverage 24/7 by the senior and the junior specialist ICU consultants. And along with these intensivists, there are primary physicians, and then the specialist doctors like neurologist, endocrinologist, and nephrologist, gastroenterologist, many other departments are there. They also come in and go as and when required. If patient requires their specialized expertise, we call them, they come see the patient, give their opinion and go. And along with that we have critical care nurses. Nurses, they are trained in taking care of these critically ill patients, very sick patients in the ICU. So these nurses are trained in the ICU, and they have a well expertise, and in our hospital as per NABH protocol we manage the ICU with these critical care nurses. And to help us out, patients who are there on the ventilator, we have respiratory technicians also. They help this for taking the care of the patients who are on the ventilator. So as a team, this is a multidisciplinary team. So this team manages the ICU patients in whole.
Okay, see doctor, so actually what are the machines or what are the other facilities inside the intensive care unit?
So actually when you enter the ICU, it is you see lot of machines. It is very intimidating, but we need to understand that it is, we should not be, the people have the idea that these machines give problem to the patient, and these are very painful. It is nothing like that. So actually these machines are used for giving certain organ supports to the patient. For example, patient who comes with a low BP or a sugar imbalance is there, or electrolyte imbalance is there, we use these infusion pumps which will be connected to the patient, and a drug is infused into the patient. So these infusion pumps help us to...
Could you please explain, doctor, this infusion pump, what is the purpose and what is the function of that one?
Yeah, we have the medicine loaded here, and this medicine injection will be connected to the patient, and the medicines will be pumped into the patient through a particular...
Actually, what is the purpose of that? Which kind of patients are we are using this kind of machine?
This is actually, if the BP is low, we start the machines, we start the medicines to get the blood pressure up. So those medicines can be given through this. Sometimes sugars are very high or very low. That time also we give medicines through these infusion pumps to the patient to manage the blood sugar levels. And electrolyte imbalances will be there, like sodium will be very low in some patients. Such patients also, through these machines we give the medicine and manage the electrolytes in the body. So, and also we monitor later on. So this is the purpose of this infusion machine. So usually when you go to the patient end, you can see 2-3 machines of this. We should not. These are for the helping the patients.
This kind of machine we cannot see in ward or any other room. No, it is not possible.
No, it usually are not used. Occasionally, very rarely they are used. But usually this is used in the ICU only, because when the patient's BP is low, patients have electrolyte, they are usually in the ICUs.
So that time we are using these
machines.
See, I have seen that this one. What is the purpose of this machine?
This is also a dialysis machine. This is organ support system. Dialysis machine means when the patient comes in with a severely low BP or because of infection, kidney is failed. So what happens is patient is not producing urine. There is a lot of imbalance happening in the body. So that time patient may require dialysis. But the patients are not, it is of the opinion that once we start dialysis, it is for permanent. It is not like that. So patient comes in sick. And because of the infection, kidney is got affected. We are dialyzing temporarily. So as and when the patient improves, the kidney function slowly starts improving and patient starts producing the urine. That time we come down on the dialysis and stop the dialysis.
Excuse me, doctor. See how it is functioning that way. Could you please just demo the parts of this?
Actually, since the patient is not there, we will not, I will not be able to. But this is a dialysis machine. When we dialyze the patient, usually a catheter is put into the patient's legs or in the neck. So that one catheter is connected to the machine, and blood comes out of that, goes into this machine. There is a filter here. So blood gets filtered in that filter, and then it goes back into the patient. So body, when the kidney usually throws out acids, electrolytes, balance will be done, so many other things. When the kidney is not working and urine is not produced, all these things get accumulated in the body. So all the things which kidney does is done by the dialysis machine. So this dialysis machine is not a treatment. It is only a supportive care for the patient. Till the kidney restarts, we are doing dialysis to support the patient.
Okay. See, doctor. Naturally, we are seeing that, or we heard the word like patients are in ventilator. Patients are in ventilator. See, actually, what is that? What is ventilator? Could you please explain?
When when the patient is having a respiratory failure. So what happens is patient is having difficulty in breathing. Some people will require 1 or 2 liters of oxygen, which we give through the oxygen ports which are there in the ICUs. So that will be sufficient. Some people will be having cardiac failure or a proper respiratory failure will be there. That time what happens is they will not be able to breathe. So what we do is we give a non-invasive ventilation. That is, we give a mask, pressurized mask. It helps the patient to breathe. So this small machine is connected to the patient through a pipe, and the mask is put on the face, and it helps the patient to breathe. So when the patient doesn't respond to the non-invasive ventilation, we put the tube inside the mouth into the lung, and then we connect to the ventilator. This is the ventilator. So these are the tubes which circuit will be there, which will be connected to the patient. So this is a ventilator which gives breaths to the patient. So it is myth that once the patient goes on the ventilator, it is one way. Patient will never come out. This is what the layperson says. Actually, it is wrong. So when the lung is not functioning, you are connecting the patient to this ventilator, and you are giving it a breath. And as and when the respiratory failure, for example, patient comes with pneumonia, and you are treating the patient for pneumonia also with antibiotics. As and when the patient improves, patient oxygenation improves, we slowly come down on the ventilator. There are different modes in the ventilators. So we slowly come down on the modes of ventilation and slowly allow the patient to breathe. As and when the patient breathes by himself and improves, we slowly disconnect the ventilator. So it is not that once on a ventilator means it is gone.
No, it is okay.
It is wrong.
See, like that ventilator, ECMO machine, we heard that one word, that ECMO machine. What is ECMO machine? What is the function of ECMO machine?
ECMO machine is an extracorporeal membrane oxygenator. Basically, it is a machine which we use for in lung failure patients or the cardiac failure patients. So usually what happens is when the lung is not, for example, in a respiratory failure patient, when the patient is not able to maintain the oxygenation in the body, that time even our standard treatments like ventilators are not helping us, and that time we plan to go with the ECMO. So that is a separate machine which will be connected to the patient, and the blood will be drawn from blood will be coming out of into the tube into the patient into the machine, and in the machine the oxygenation happens, blood oxygenation improves, and the oxygenated blood is given back to the patient. So we are bypassing the lung here and taking the blood away from the lung and giving it into the ECMO machine. ECMO machine oxygenates the blood and gives it back to the body, and again this circuit will continue bypassing the lung. So when the lung is injured, for example in a severe influenza pneumonia is there, or patient is having a trauma, for RTA has happened and lung has got injured, that time patient is waiting for a lung transplant or other things. That times, or else till the lung becomes starts oxygenating back. Till that time we continue on this ECMO machine. And then once the oxygenation lung starts improving, we slowly disconnect the ECMO machine and come back on the ventilator.
Okay, doctor, this using ECMO machine, it is a recent update, that one. That means, see, usually we are seeing that ventilator. Now gradually it came. What is the criteria for using ECMO machine in patient?
ECMO machine is not a replacement for ventilator.
Yeah.
It is the ventilator is a standard treatment. Not all patients can go for ECMO. So first initially we treat the patient on the ventilator.
Yeah.
And 99 to most of the patients come out on the ventilator. 99.5% of the patient come out on the ventilator.
Yeah.
There's a very few patients who deteriorate and may not. The standard treatment is not sufficient for them.
So such a patient, when we are applying ECMO machine, what will be the experience?
The thing is, we have done means what we have done in our hospital. In our Manipal hospital, we have done 2 ECMOs before. Recently, previously we have done around 4 years or 5 years back, we have taken 2 ECMO machines. But what used to happen is we did not have the machine here. Even during COVID times also we required ECMO machine because oxygenation was getting better in the lungs. We had to put a ECMO. In Bangalore and in the metropolitan cities, lot of ECMO machines are available. So they have put in and out, they have used the ECMO machines. But what happened for us is even during COVID, we did not get the ECMO machines because they were not there for our disposal. So and these machines are not there in Mangalore, and we had to call Bangalore or Chennai to get these machines. Either they never reached us or the machines were not there at all. So we couldn't use much of it. But 5 years back before COVID, we have done 2 ECMO treatment for our patients here, and treatment it was good. And presently our Manipal hospital, I am proud to say that in association with Dr. Madan's ECMO Healthcare, we have stationed an ECMO machine in our hospital here itself in Mangalore. It is there for the use for all the patients in our region and from the North Kerala or any other place. So these their team is there. They, whenever the requirement ECMO is there, they go stabilize the patient, put the patient on ECMO in that hospital, and then get the patient here and continue the treatment here. Okay. That is the kind of setup we have made now.
Okay. See, Doctor, one doubt is that because of that, it is so expensive when the patients are in ICU. Naturally, we heard that it is more expensive, the treatment. Why it is heard?
Actually ICU treatment, as I said, there are different kinds of ICUs. Level 1 and level 2 ICUs, patients are stable and they are just monitored. There the cost won't be high. But when the patient is very sick, what happens is when the patient comes in, patient is not stable enough, BP is not there, pulse is weak. So we have to stabilize the patients. So there are so many procedures we do to get the BP up or to do all this one. Patients may have organ dysfunctions. So they may require dialysis or a ventilator. So the cost of
this kind of multiple support will come, naturally the cost
will increase. And also when the patient comes with infection or any other condition to the ICU, we have to see what has happened to the patient. So initial first 2 days we send a lot of investigations, blood test to understand the nature of the illness. So all these investigations also cost and inflate the cost. So but these costs will be there only for first 2 days. After this, from 3rd day onwards, only all the catheters are there, investigation frequencies come down. So the cost comes down from the 3rd day onwards.
Okay. See, Doctor, we have seen that visitors are restricted in entering ICU. See, whether it is relative or any other friends. Okay. Why? What is the reason?
The thing is when the patients are in the ICU, it is definitely a very emotional state for the relatives. Understand, everyone wants to come and see the patient. But what happens is more number of people coming in, we don't know which person is coming from which part. So someone must be traveling from Chennai and coming directly and seeing the patient. He may be carrying an infection. He may give the infection to the patient. So our patient, your own loud patients who are there in the ICU are immunosuppressed. So the people you coming in may give the infection to the patients. So that is the main reason we try to avoid more and more persons coming inside the ICU. And we also request them to wear the mask like that you are wearing. And also we ask them to use the sanitizer rubs before entering the ICU. They have to rub their hand properly, clean their hand, wear the mask and remove their slippers and then come. Try not to touch the patients and limited number of people, only 2 or 3 people should visit regularly to the patient.
Okay. See, Doctor, this kind of life support withdrawal, what is the recent Supreme Court order?
Actually, this word itself is half. Actually, withdrawal of life support. Actually, the word should be withdrawal of life support in terminally ill. Actually, this is not the means everyone says that withdrawal of life support. So, a patient is on a ventilator, dialysis. A relative cannot come and ask us withdraw the life support. We have a code. It is not like that.
Okay.
It is only for the terminally ill patient. The person who is terminally ill, we are giving treatment and treatment is futile. And we know that patient is not going to recover. Such cases we ask the primary consultant will discuss with the relatives and relatives also agree. That time we can go ahead with this withdrawal of life support. Okay, this is only for the terminally ill, and that also it cannot be done unilaterally by the doctor, and the relatives. So there is a protocol which is set in by the Supreme Court. So in the hospital we need to have an internal committee requiring many other patients like doctors like anesthesiologists, intensivists, neurologists, many other doctors will be there in that panel. So as a doctor and a relative, once we decide that we want to withdraw the care because of the terminal illness, the case will be referred to this internal team. They will see the patient, they will assess the patient, and they decide whether he is a candidate for withdrawal of the life support or not. And once they agree, the file will be sent to the district health officer. So district health officer has to approve that. Once the approval comes from the district health officer, we tell the decision to the relatives, and then at their good time and whenever they say withdrawal of life support can be done. So this is the process as per which the Supreme Court tells us to go ahead for the terminal. And even Karnataka last week has told us to implement this law. Karnataka government has told us to implement this law.
See, doctor, as an HOD in KMC, Jyoti KMC intensive care unit, how long you are working here?
I am working almost like 13 to 14 years now in this ICU, and initially the critical care department was not there. So when I joined in, we started from the base and built up the team, and slowly we have come to this unit here, newer unit which is passed. We are around 24 to 25 bedded multidisciplinary ICU here, and we have other ICUs also like neurosurgical ICUs and cardiac ICUs, level 1 and level 2 ICUs are there, different ICUs are there. So basically our team is managing the medical ICU here for full-fledged, and all kinds of organ system supports and every kind of international standard treatment is as per protocol is given here in our ICU.
See, already you have explained regarding this one, ECMO machine and all these things are, all the treatments are, all the facilities are available in Jyoti KMC hospital.
Yes, we have all the whatever things have been explained, everything is there. So we are trying to manage the NABH levels, ICU standards, and we also have we just don't boast about it. We have internal audits also, internal and external audits also. Depending on that we scale ourselves. So every time we have given the best results, and presently I can proudly say that ours is the one ICU with the more than 80% of occupancy in this region, and we are serving the North Kerala and other patients coming from that area also, and we have recruited so many patients from the other hospitals and given the best treatment here.
See, doctor, as a tertiary care center, how Manipal Hospital is managing this remote area?
So we are having lot of referral unit areas, referral centers in the peripheries, and also we have satellite centers where the doctors are present 24/7. Patient come there, they discuss with the doctors here, stabilize the patient there and start the treatment, and then shift them here for the definitive treatment.
That area is in Karnataka state only or other than
no, we have multiple places, we have referral centers. For example, in Chervatur also we have, and in Puttur and Kakkinje also we have. So this helps us to improve the starting the treatment early and improve the patient care. And also we have Mars ambulance which is stationed in multiple places. So these ambulances have life-saving equipments and trained technicians in the ambulance. They stabilize the patient and safely transport the patient till our hospital, and then we take over. So the Mars ambulance also is making a huge difference in the care what we are giving, because the initial stage treatment matters a lot.
മെഡിട്രാക്കിൻ്റെ ഇന്നത്തെ എപ്പിസോഡ് ഇവിടെ വൈൻഡപ്പ് ചെയ്യുകയാണ്. ഇന്നത്തെ എപ്പിസോഡിൽ ഇന്ന് കാസർഗോഡ് പ്രേക്ഷകർ കേട്ടത് ഇൻറ്റൻസീവ് കെയർ യൂണിറ്റിയെ കുറിച്ചാണ്. നമ്മൾ സാധാരണ ഒരു രോഗിയുടെ അല്ലെങ്കിൽ ഒരു പേഷ്യൻറ്റിൻ്റെ ജീവൻ രക്ഷിക്കുക എന്നത് വളരെ മർമ്മപ്രധാനമായ കാര്യമാണ്. അതിന് എത്രത്തോളം അത് ഏതൊക്കെ രീതിയിലാണ് അല്ലെങ്കിൽ ഏത് ഡിപ്പാർട്ട്മെൻറ്റിലാണ് ഇൻറ്റൻസീവ് കെയർ പോലുള്ള ഇൻറ്റൻസീവ് കെയർ യൂണിറ്റ് പോലുള്ള അവിടുന്ന് ഏതൊക്കെ ഫെസിലിറ്റീസാണ് നമ്മളൊരു രോഗിയുടെ ലൈഫ് സേവ് ചെയ്യാനുള്ളത്. ഈ വിഷയമാണ് ഇന്ന് ഡിസ്കസ് ചെയ്ത് ഈ വിഷയത്തെക്കുറിച്ച് കാസർഗോഡ് വിഷൻ്റെ പ്രേക്ഷകരോട് സംസാരിച്ചത് മാംഗ്ലൂർ ജ്യോതി KMC ഹോസ്പിറ്റലിലെ ഇൻറ്റൻസീവ് കെയർ യൂണിറ്റിലെ HOD ഡോക്ടർ ദത്താത്രേയ പ്രഭുവാണ്. സർ, താങ്ക് യു സർ.